So, yeah, what I wanted to do was just as a sort of setup before the speakers begin and we go through the questions, is just explain why would group clinics interrupt inequity and inequality, and also give you some examples and some insights from the evidence base. So the research suggests that inequity stems from the interplay of three different factors: an individual's sort of lived experience and life, the structure of the way that we deliver services, and also that sort of institutional norms. And these three things are all disrupted by the group clinic model. So the first thing that happens when you're in a group of peers with similar lived experiences is that it's massively validating for your own personal experience. And that's not something that you can get in a one-to-one appointment with a clinician. That peer connection, that fleeting connection with relatable peers, and also the deeper relationship that you, an understanding that you gain from with your clinician in a group clinic, creates social capital and inclusion, and that's a really important driver for reducing inequality. The fact that the group clinic actually supports active participation from the group, and the clinician is constantly encouraging the group to share their thoughts on the subject or their experiences of treatment, really supports decision making and self-management. And of course, being in a group together as opposed to that one-to-one appointment is a massive disruption of the way that patients are used to a clinical appointment being structured. And so that completely resets their expectations, and it provides us with a really fresh start to work with patient groups who perhaps are really very cynical about health services and institutional norms. And then finally, we've got the issue of power. And, we know, if we're honest, that, it's very, very hard to change culture. And that's what I actually love most about group clinics, because they're just a Trojan horse for completely disrupting the power dynamic between the medical model, the medical institution, and patients. They completely put patients in the majority. The patients are setting the agenda before the clinician even walks in the room, and they are in control. And the clinical tasks that need to be done get done too. So everybody gets what they need out of the interaction. And all of these things mean that what we've found in studies is that the group clinic model engenders much higher levels of trust amongst patients, and they perceive the quality of the services and care they get in a group clinic as higher compared to a one-to-one. So this is fundamentally something that is going to change the way we deliver clinical care in a way that offers a lot of hope in terms of inequity. Next slide. So there's other practical things as well. So it's not putting an individual on the spot. It allows people who like to listen and learn to sit back and do that. I keep mentioning this level of trust, but I just think it's absolutely key. It's building patients' confidence, which is key to, helping them to move forward in their lives. Their peers provide motivation and inspiration. You can deliver it in a trusted community place. It may help to overcome health literacy barriers, because it really enables us to talk to patients in everyday language, and it really puts a spotlight on that medical jargon and forces us to explain things in ways that are much more accessible. There's research shows and measured improvement in activation measures in group clinics, and we can use the group model to much better personalise care to the needs of different communities, to those with protected characteristics, and even gender. So we can do female-only group clinics, male-only, people who identify as with other LGBTQIA plus. So we're kind of, it's there's so much we can do to make this really personalized. I'm sure that we'll talk about digital inclusion today, and that the speakers will mention that. But, nudging people to be able to attend a video group clinic may actually help us to engage people and get them out of digital poverty and exclusion. And it may be a bit of an impetus for that. And you can use this across all ages, including with children and young people, where we know there is masses of need, particularly around mental health. So next slide. So this is some of the evidence. I want to be honest and tell you that the evidence around group clinics and its impact on inequalities is limited, but there is some, and it's in type 2 diabetes and antenatal care. So, and most of the work has been done in the US. So in terms of diabetes, there is evidence that adapting the group clinic model to the cultural needs of low-income Spanish-speaking Latinos improved control compared to one-to-ones. And a narrative review of 14 studies found that the group clinic model impacted the most on low-income and underserved individuals and resulted in superior preventative care. So that is a really interesting finding from what is in effect a systematic review. And then in pregnancy, young pregnant women from ethnic communities and low income from low income parts of the community in the US were studied using the centering pregnancy model. And this had positive impacts on birth weight, on use of intensive care services for newborns, on their psychosocial stress, which was less, and at follow-up as well, 1 year postpartum. And also they gained less weight and they lost weight quicker. So it's a small seed, but it shows that there is something in this, I think. Next slide. And finally, just to let you know some of the pieces of work that have been done, but there is so much room for more innovation and testing of this model in England. These are some examples of group clinics that have been tested. So group clinics for Turkish-speaking people who just refuse to engage with mainstream primary care to get their type 2 diabetes reviews, group clinics for Roma people with severe and enduring mental health, where we know there's massive inequalities around physical health checks. They got theirs in a group clinic delivered by primary care and a CPN, and working with children from disadvantaged families with poorly controlled asthma. And similarly to what I'm sure Rupa will mention, in that study, they reduced hospital admissions and presentations quite significantly in that group. But it was a lot of work to get the families to come along to the group clinic in the first place. And the GP had to really, persevere with the parents, but once they got them in the room, it had a huge impact. So that's just setting the scene from my point of view, and we're going to move now to moving to the panel discussion. Oh yes, how could I forget, just before we do that? I also just wanted to point out the fact that, group clinics don't only impact on patients, they also have a massive impact on staff. And, if we're going to improve the quality of care, which improving and addressing health inequalities is all about, then that is also very important. And there are massive psychosocial benefits from staff around an increased sense of autonomy, a deeper connection with their patients, a sense of joy being restored to practice, and all of that has the potential to impact positively on retention. And there's some early signals from some of the work that we've done that it might indeed have a very positive impact on retention. So that's just a little bit of an overview to get us going. And we've got some great experts in the room today who are going to share their thoughts. Today is not about necessarily sort of coming up with all the answers. It's about discussing what can we do, how can we get this model going, because we've got the 10-year plan that we have to deliver, and group clinics can be potentially such an enabler of the delivery of all 3 shifts in the 10-year plan. So let's, without further ado, move on to the panel. So I'd like to start by, if I can get our speakers to all pop their cameras on, perhaps, if that's okay, if you haven't got your camera on already. And I think we're going to take the slides down, aren't we, Alicia, for this bit, because we don't actually need the slides, and so that you can see our speakers today. And I'm going to start, if I could come perhaps if I could come first to you, Lauren, if you'd just like to introduce yourself and also just tell us what your thoughts are around the potential of group clinics, and perhaps any experience that you've had so far that you'd like to share with the meeting.
Absolutely. Can you hear me okay, Georgina?
I can, yeah.
Lovely. Well, it's lovely to see you all today. So I'm Lauren Watts. I'm a medical oncology registrar by background, and I'm actually a health inequalities improvement clinical fellow this year. So I'm on a year out of training, and I probably describe myself as one of the newer converts to group clinics. Now, before I actually did this post, I had relatively limited experience of group clinics, but I should just say that I know they've actually been around for a while. I know Georgina and Rupa have been working very hard on this, as have many of you on the call. And I'll just share a little bit about my experience from an oncology perspective. Of course, as many of you are aware, we use group clinics, particularly around the prehabilitation aspect before many patients have surgery, and particularly for their pre-chemo talks. And that's not just around education, but as you say, a clinical aspect, which is typically nurse-led. And last year I worked at Kent Oncology Centre, which was fantastic. And these group clinics for the pre-systemic anti-cancer treatment talks were led by my nursing colleagues. And the structure varied ever so slightly differently to what we've just covered, but was generally very similar in that there were typically 2-hour clinics. They would have 6 patients, and it would start off with a little video. Then the nursing colleagues would give a very good overview of what was required pre-treatment. And then as an incorporation of that, they would each have 15 minutes one-to-one time with the nurse. And the feedback on that was fantastic. And I was going to say, just from what Georgina had said in terms of the patient experience, I couldn't get over just the, I guess, how impactful the social connection aspect was, and how the qualitative aspect of feedback was people felt less lonely. There were amazing friendships that were made that you just, between people you'd never anticipate requesting treatment on the same day. And although per se this isn't specific to health inequalities, what I would say is, of course, it does free up time. So of course that 2-hour window for that clinic meant that they were saving 4 hours in total overall. So productivity was better. And of course, that means we can then focus our energies on the one-to-one appointments, sometimes with people who need those appointments most, whether that's people who don't speak English as their first language, or, for example, people who have autism who find those group settings very overwhelming. And since being on this programme, I found out so much more about the evidence base and really how well people are doing in terms of rolling out group clinics. So I'm really keen to spread the message more and, as you say, spread and scale this fantastic work. Yes, so it's got my full support, and I look forward to sharing a bit more about the health equity aspect later.
Amazing, that's great. So if I could come to Paul next, if that's okay, Paul.
Yes, thanks, Georgina. Hi, colleagues. It's lovely to be with you today. I'm Paul Gavin. I'm the Deputy Director for Equalities and Involvement, and I sit in the Nursing Directorate of NHS England's central team, along in a division called People and Communities. excuse me, I'm not a clinician. I think I want to put that out there early. My sister functions in our division are insight and voice and experience and partnerships. And holistically, we are really interested as a division in patient empowerment, health ownership, and enhanced patient experience. And that's where we tend to talk about group clinics. And this is where we tend to offer group clinics from our coaching perspective to systems that are looking for ways to maybe change their model a little bit. And as you can imagine, with the 10-year plan discussions ongoing at the moment, we are being asked at centre to try and provide some of the, the delivery detail to complement this high vision plan. And group clinics are one of the tactics that we would bring in inevitably to conversations with systems that are looking to, think about these neighbourhood health services, etc. Crucially for us, we see group clinics as providing, they're kind of evidence-led. We've got the case studies, we've got the empirical data, the academic papers, the things that you would expect as a professional thinking about changing a strategy along these lines is there. And that allows us then to approach professionals with confidence and say, have you thought about this? Because as we all know on this call, to get a professional to change their minds or their tactics usually involves, an overwhelming amount of evidence, myself included. But some of the highlights that we would pick out would be that our division and the things that we are interested in, what we see in group clinics are the fact that patients become active participants. This thing about agency in sessions, they contribute to the learn and they contribute to and they learn from the discussions, which are, I think, crucially in terms of power, often more relaxed, supportive, and less rushed than we sometimes find, when we were in traditional appointments. Often there's extended time given to these conversations to allow for a deeper understanding, of conditions and treatments, and that builds confidence in people and literacy, all of which health literacy, which allows this power dynamic to be altered. We see group settings as shared learning environments that reduce stigma and isolation, and particularly for people from seldom heard communities or living with long-term conditions. And I think that's key. Group clinics and the case studies that we have seen, particularly the diabetes model, which again I would endorse heavily, culturally tailored in their relevance, and that builds trust. To wrap it all up, we think peer learning validates lived experience and it boosts confidence for people to manage their own health, which is central, I think, to the shifts that West Streeton is hoping that we can get our arms around and promote and change that culture. I'm going to pause there, Georgina.
That's amazing. And I mean, it's just a couple of things to reflect on before I get Rupert to introduce herself is, everybody's looking at the 10-year plan and going, oh my goodness, how on earth am I going to fit in prevention? How am I going to find the time for all of this? And the irony is that if you do a group-based approach, you're actually going to save time, as you said, Lauren. So we can save clinician time and deliver the time for our patients. I mean, I know I'm completely biased, but what other intervention is there that is actually going to do that for you? And I think that's, a sort of, that's almost like the foundation, isn't it? And then on top of that, if we can actually start to address inequity, how amazing would that be as well? So over to you, Rupert. Come in, Rupert.
Thank you.
I feel like
Georgina.
I'm on Eurovision Song Contest.
No, you don't want to hear me sing. So my name's Rupert Joshi. I'm a GP and I've been doing group clinics since about 2018, 2019 in my practice. And we've got a really good team now. Using the pharmacy team, a health and wellbeing coach, our care coordinators, our practice nurses, and we've got a lifestyle type medicine type doctor as well, who's working in the practice delivering on some of the targets that we have to do anyway for QOF. So we do them in a different way. And we're also using them to reach some of our populations. I think that the beauty of the group clinics is that you can really use your population health management data to target the population that you really want to see. So, for example, if there are patients, say perhaps children from deprived communities, who are bouncing in and out of A&E, who are going to 111, who are coming to the surgery a lot. One of the things that we did was we organised a minor illness for under fives session, and we targeted those patients that were doing that, and perhaps they needed a little bit more of a wraparound care around them. So we did that, in September time before winter strike, so that we've got real good advice and care planning. And I think the beauty of what, building on what Paul said about the neighbourhood health, is that actually in a group clinic, you can bring in a multidisciplinary team, and it doesn't have to just be from your practice. For example, you could ask a secondary care consultant to come in. You can get voluntary sector to come in. So one of the things that we've done is, we've got the health visitors in. We've got for our postnatals, we've targeted those patients that really need our help, perhaps from underserved communities. And we've got the charity, the breastfeeding network, to spend a bit more time and give them their expertise of infant feeding. And it's a way of delivering neighbourhood health, because neighbourhood health is all about, and there's so many definitions, but for me, it's about delivering care to the patient in a way that makes sense for the patient. It's the easiest way of delivering care. And we can say that it's the easiest way of delivering care for staff as well. And it's anything that's outside of the hospital. So in this way, we can bring in our frailty teams, we can bring in our district nurses teams, we can bring in our social prescriber, we can tackle loneliness, we can look at carers. What do the carers need to have this kind of support? We could look at patients with leg ulcers who feel very isolated and smelly, and they don't want to be in the company of other people. So we can get them together and they can feel less isolated and alone. We also do menopause group clinics every other Wednesday evening in our extended hours. And what we're finding is we're having patients from different ethnic communities coming in, which perhaps they didn't feel as confident that, but the word spread within the community, and people are coming, and we're talking to them about cardiovascular health, we're talking to them about bone health. So at that age, kind of 40s, 50s, they're getting that advice and reassurance about aging well, and we're doing blood pressures with them, we're talking about cholesterol with them, we're talking about diet with them. And the other one that we've done, which is in combination with our MOS community, is, we asked them what would be helpful, what can we do to help you? And the ideas came from the community. And they said, we notoriously eat quite badly during Ramadan because we're fasting. And then when we break our fast, we're eating really unhealthy food. So can you give us some advice on what to do? So we did a group clinic on video. And patients asked questions, and we went through their specifically questions on keeping well. We talked about physical activity, and generally, we called it keeping well during Ramadan, but it was really holistic, and it was about using lifestyle and answering lots of questions from the community. So using your population health data, you can reach people, and you can use your voluntary sector, you can use your community assets, and you can bring people into that multidisciplinary team to deliver that personalised care, that prevention care, keeping people well, and really bringing care closer to home. And it can be virtual, it can be face-to-face. But I think my message is, think about those communities that aren't coming to see you. We did a project on mental health in Black people, because we realised that actually the depression percentage was 7% in our Black community, 8% in our Indian and Pakistani communities, and 14% in our white communities. So what can we do to bring people and be more approachable and cut down those stigmas? So it's about developing those community assets and talking things through. And group clinics is such a good way of delivering that care. and getting patients to talk to each other and really forming that network of support. I don't want to take over the whole thing, so I'll hand back to Georgina.
Well, I think you've really, what you've done there, Rupa, as well, is you've kind of, we've started to go into that second point, haven't we? You know, around inequity and how we can, you know, why does the group clinic model offer hope, you know, to support with inequity? And I guess just picking out a couple of the things that you've just mentioned there to start us off on that part of the session, you know, if you can harness your data, so you can use your population health data to better understand the needs of your community and what's really going on with different demographic groups or different geography, people living in different parts of your PCN, or, you know, parts of your locality within your practice, and really start to hone in and then offer them a group clinic that speaks to the needs that they have, you know. So we can get really creative with this and bring in those community organizations who maybe already have links with the people who are not coming to our practice, you know. So that would be two of the things that I'd pick up from what you said there. And I also love, you know, that MDT element that you mentioned, so that, and the evidence is that from systematic reviews that group clinics support MDT working. Now, there's not actually that many clinical interventions or, you know, care models that have been proven to support MDT working, and that's better compared to one-to-one appointments. Again, you know, it's that systematic RCT review. So Lauren, can I come back to you on that one as well? So, you know, I mean, you're sitting in the inequalities team at NHS England. Your whole life is spent thinking, how do we do this? How do we address inequalities? What have been the light bulb moments for you in relation to the potential of the group clinic model, specifically around inequity?
I was going to say just how much it aligns with so many of, I guess, our strategies and policies as well. So it's probably quite helpful for us to kind of think about my team's vision as such, which is very simple in terms of equitable access, excellent experience, and optimal outcomes. So just thinking about the access part, first of all, we, of course, you mentioned about the types of group clinics we have. So I love that obviously we've got virtual and we've got in person. And I would just say how imperative it is to have both. Of course, those who have poor mobility are unable to get to clinics for whatever reasons, and therefore can hop online. And that makes it easy for them in terms of usability. And of course, those who mentioned who are digitally excluded, or, you know, various other reasons, who need that face-to-face time and can therefore go to a group clinic. I love that. And then we touched on a little bit about the clinician time, and then sometimes when it might not work, which isn't very many times, because I've been trying to reflect on that as well. But, you know, we're freeing up that clinician time specifically for those more complex patients who need us. In terms of experience, again, as you've mentioned with some of the evidence, it's quite overwhelming how positive it's been. So Rupa and Paul had mentioned about the peer support aspect, and actually being people feeling that they're in it together and feel some element of being more comfortable and more willing to be open. And there's been reports that there's a decrease in the stigma associated with it. Often, of course, when we're having our one-to-ones and we're asking some challenging questions, people understandably feel put on the spot or judged and don't want to open up. So again, just having some of those barriers broken down is brilliant. An interesting one I found for the feedback was that people felt more listened to, which again, I reflected on as a clinician, thinking that surprised me in a way. But again, having others, not just the clinician, to listen to them, and as you said, the wider MDT, but also that element of more time, that more focus, that more energy on them, and therefore they felt more empowered and they had better understanding and could therefore self-manage things better, which kind of brings us onto the outcomes aspect, which again, when people feel more energy and more understanding to actually manage their complex conditions, the outcomes improve, whether it's a change in behaviours, which again, it'd be fascinating to find out more about behaviours and culture, because we often say about cultural barriers, but what do we mean by cultural barriers? What learning can we take? What qualitative analysis can we do to really specifically hone in on our local populations? Adherence to treatments, better disease control. We mentioned the blood sugars, we mentioned about antenatal appointments and actually improved birth weights. I mean, the evidence is really brilliant. The only thing I would say is from a health equity perspective and thinking more about the index of multiple deprivation and thinking specifically about ethnicity, we don't quite have that data there. And so it would be fantastic to start really collecting that more routinely if possible.
That's amazing. I mean, there's, those are loads of kind of person-centered benefits as well, aren't they? Just about making the whole experience so much more relevant to that individual. Paul, what about from your point of view, thinking also at that really strategic level about people and communities? I know a big part of what you guys are trying to embed is co-production within every part of the NHS. What do we know about inequality, people who feel maybe less included in our just, current system? How could this really help enhance co-production and get them engaged?
Yeah, I mean, I will answer that, Georgina, but can I go +1 on Lauren's last point about measuring the equity impact? I think this is so important going forward. Track participation. This is the things that it does routinely now. Tracks outcomes, tracks the experience. These are things that I just want to emphasize that we would say. In terms of this seldom held voice, we know. I mean, it's in the stats. That the groups that we are not talking to routinely are generally, wrong. The groups that we're not hearing routinely are generally in, as Lauren said, that IMD core 20, in terms of, being left out of the kind of outcomes that we expect everybody to enjoy. Georgina, I think that for systems that are looking to get their arms around this and do it well, would target their group clinics, in high need areas, and looking to commission the models in communities with that highest burden of disease. And importantly, and you said it in your handover to me, if you're going to do it, talk to them before you do it. Ask them what they would like to see, co-design and co-produce, ensure the clinic is shaped and informed, and therefore you will 100% ensure that it's culturally appropriate, language accessible, grounded in lived experience, all the things that the best clinics have, you can choose to have from the beginning. I think that there's a tendency, and probably people like us are very, very guilty of it, of, thinking, well, this is a great plan, let's do this. Well, let's talk to the communities that are living the life. They might have a point of view. They might be able to affect it in a way that you do it so much more efficiently. And of course, that then bleeds into the other side of that coin. If systems are considering it, then there is a huge investment required in training and infrastructure. If you're going to have people running it in a manner that makes the clinic different to the point of view that it gets impact. And I see it as part of the innovation that we're being demanded to bring in terms of a 10-year plan. Then the models that are running at the moment are fantastic, but I have no doubt there are other models out there that can quickly come, alongside it and change it subtly to meet the need of the community that is actually we're looking to engage with. I could talk all day about it, Georgina. I'm going to check in and go for questions, but yeah.
Well, we are getting on a little bit with our time as well, and so what I'm thinking is let's combine the last little bit. So as well as we've got, I'd say I mean, I haven't had a chance to look at everybody who's in the call, but there's a lot of people at practice level here or PCN level, as well as more that kind of ICB system level. So what would be really good, Rupa, I'll come to you first, is if you could give those some advice. If you're working in a sort of PCN level, what would be your advice to people around using group clinics as a tool to address inequality? And if it was you, I mean, you have done it obviously in your own practice, but if you're sitting in a PCN now, faced with your role in delivering the 10-year plan, what would be your quick win, if you like? What would be the model what would you go for? Let's get quite specific to give people some ideas. And then hopefully if you can all do that quickly from different perspectives, then we might have a time for a few questions. And everybody, if you've got questions, do pop them into the chat. I've been answering a few questions as we've been going along as well. So Rupa, Hope that
Right.
challenge is okay.
Yes. So I think, I mean, some of it is looking at your own population, isn't it? And what's your population? What are the problems you're trying to solve? What are frequently, what's problems are people coming in with? Do you have a huge diabetic population? Do you have a lot of South Indian populations with a lot of diabetes, for example? Or do you have, when we looked at our population data, we realised we had lots between 40 and 55, and we thought, why is everyone coming in with a menopause? Oh, that's why, because we've got a big bulk of our demographic in that age group. So do you have a lot of asylum seekers? Do you cover hotels? What would make your life easier, and how could you optimize healthcare for your patients in those populations that you're finding challenging, let's say, to manage, and they're taking up a lot of appointments, taking a lot of time, and you're never really getting to the bottom of treating them and finding out what matters to them. I mean, for us, in my surgery, I think we were looking at the QOF cholesterol, and we just thought, goodness me, there are so many patients with hypertension. We never make our targets because we've got over 1,000, 2,000 patients on the hypertension register. So for us, I think the biggest difference that we can make is cardiovascular health, cardiometabolic diabetes, and looking at our dementia populations, because now we know that hypertension is a risk factor for dementia. That has been a really good hook for me with my patients, because I can say, if we control your blood pressure, if we look at your lifestyle, if we look at lipid management, that could reduce your risk of dementia. And people have been, because I think they know about heart attacks, they know about strokes, but that's been a really good hook for me. So for me, I think it's tackling CVD, and CVD is a priority as well in many ICBs at the moment, and it's a QOF priority. So you're really, doing everything at once by looking at and tackling CVD risk. And
Yeah.
I know the CVD prevention team are also looking at piloting some surgeries or PCNs that are looking at doing this. And for me, it's embedding the new pathway of care as business as usual. So how do you organize your lipid management, for example, when you're reporting on your blood tests? Could you add a drop-down menu that says see in group clinic? When you're doing the blood test, can your healthcare assistant or your phlebotomist or your nurse colleagues, can they say, oh, you'll be reviewed with your results in a group clinic? Can your receptionist say, you're on the QOF register for hypertension, there's our pod, can you do your blood pressure? And as you're doing it, you can be followed up in a group clinic. So it's embedding the new pathway of care within your practice as business as usual. And then using your data to reach some of those patients that aren't coming in, perhaps by doing health inequalities health checks. Something that we're doing in our locality is going out to faith centres, using our local authority partners to do health checks, so blood pressure, cholesterol, etc., diabetes, blood sugar monitoring in the community where the patients are, and trying to then improve their cardiovascular risk factors.
Amazing. CVD is definitely flavour of the month right now, isn't it? It's everywhere. Everybody's talking about cardiovascular disease prevention, and I'm very glad to know that it also impacts on dementia prevention as well. That's really important. We are rapidly running out of time, but just a very quick final sign off. I think you should, Paul and Lauren, you should tell us what's your priority. If you were in the place of doing group clinics today, what would you do? How would you use them for inequity? Just keep it very brief. You've got a 1-minute pitch. And whilst you're doing that, I think that probably Alicia will start to put the slides back up so we can just tell people how they can get more help to get going with group clinics before we close. So Paul, over to you next.
Yeah, I'm not a clinician, so I have to qualify that. But for us, we would see more clinics in deprived and ethnically diverse communities with that have a high prevalence of poor outcomes. I think alongside that, we'd be looking for setting them up where there's a strong evidence already for improved self-management. And lastly, with an opportunity, as Rupa said earlier, to provide that wraparound support which I think is which puts the cherry on the icing on the cake. Thank you.
Absolutely. Yeah. So, you know, Sunita's posted in the chat that, you know, menopause, I think menopause and CVD, I don't think we should see them as two separate things. I think we should be looking at menopause and CVD prevention as one thing. You know, honestly, it's the same thing. So that's just my perspective. Lauren, give us the final words.
Well, I think I was going to say, with the menopause aspect, you've chosen my one. As an oncologist who's interested in breast and integrative oncology, I push most of my patients into menopause. I think we've got a brilliant model of how that works already, and I know Sue Mann's team has done some great work around that as well, and we can see what works, and they've got some great measurements. So again, learning from all of that and scaling up, and as you say, two birds with one stone. What are the implications? CVD from that, osteoporosis, you know, the list is endless, and a holistic approach in terms of the other holistic ways we can help control that. And I do just have to say one more, which is, of course, I always want to say about children and how we should really focus on them in terms of the future, and thinking about the importance of asthma care, inhaler relief, and that side of things from group clinics. Again, amazing evidence around that. So yes, we really need to invest in that younger population too.
And we haven't even mentioned that much about early years, really, have we? And early years is when you set the blueprint for your health and for your life, you know. And if we can do stuff around supporting parents who are vulnerable in those early years, that's something we're very passionate about at ELC as well. So I'm going to pass back to Alicia to take us to the end of the session. Please do stay on. We want to tell you how to access support to get going with group clinics, and ask for some feedback. And I'm going to look at the questions in the chat in the meantime and respond to those.
Thank you, Georgina. So yeah, I'm just going to give you a bit of a brief overview of how we can help you get going with group clinics at ELC. So we have been working with teams for just over a decade now, gathering knowledge from best practice to construct a learning platform that trains you on how to deliver group clinics, but also importantly, it helps you to embed them and overcome any known barriers and sustain your embedding of group clinics too. So here you can see the support program. So on the left-hand side of the arrow, we have our orientation session, which is a 1.5 virtual live session to get your team aligned and ready to launch, looking at your plan. And then we have the 3 training modules accessible via the platform, which includes simulation training, a simulation of what a live group clinic looks like, basic training, which is the nuts and bolts, core principles of group clinics, and then finally the advanced skills training, which is really looking at managing group dynamics and communication styles, etc. All of the training is fully virtual, so you can pause and play when you are ready or when is convenient, which helps to minimise disruption to your patient care. You will also get 12 months access to the route map and learning platform, a bank of resources of templates that you can pick up and use when you need to, and you have access to our support desk and monthly web